Great, we'll get started. So welcome to ROVER 2.0. Today we'll be doing palliative care. We have a great lineup today. We can go to the next slide. We'll have the panelists introduce themselves and tell us a little bit of why or how they got into palliative radiation oncology. Just some ground rules. If you have a question, put it in the chat or the Q&A feature. Make sure to put it to everyone instead of just hosts and panelists so everyone can see. And with that, we will get started. So Dr. Johnstone can start.
Hi, I'm Candace Johnstone. I am a professor of radiation oncology at the Medical College of Wisconsin. My journey into palliative care as a passion started with my first faculty job at Dartmouth Hitchcock Medical Center, where because of the rural nature of a lot of the practice, patients would drive sometimes for 2 or 3 hours to come for treatment. And I started looking at the data again, more carefully because it mattered, and saw that there was lots of good supporting data for hypofractionated palliation, but yet it was infrequently used, and started using it. And I think once you start using it and see how wonderfully it works and see the limited toxicity, you'll never go back. And so that has just intensified. And I've decided I can't change some of the established faculty, but I love teaching residents because if you learn it now, you'll go out and practice and actually use some of these basic tenets of palliative care. So thank you for having me. I'm delighted to be here.
And I'm Zach Kahutek. I am faculty at Vanderbilt University. I got into palliative care. I finished residency in 2016. I was at Memorial Sloan Kettering and was thinking, trying to figure out what I wanted to do with my life. And they were, the chairman there was starting a palliative program, or really a metastatic disease program, because we realized that there were patients that we were seeing inpatient that were very near to end of life, and a huge proportion of patients that would just bounce around in the med-onc clinic, going from one clinical trial to the next, not getting their symptoms effectively palliated. So he pitched the idea of, what if we just started a metastatic disease program? We could treat oligometastatic disease, palliative care. And I fell in love with it. I was there for 2 years, and then Vanderbilt had a need in the inpatient palliative space, and I came here. And like Dr. Johnstone said, don't want to go back. And I guess that's enough of my story. Thanks for having me.
My name is Josh Jones. I'm at University of Pennsylvania, where I've been for a number of years now. My story is a little bit different. I was doing residency and had similar revelations to Dr. Kahutek and Dr. Johnstone, thinking about different ways that we might think about optimizing care for patients who needed palliative radiotherapy. I was particularly distraught by how inpatients were always seen at the end of the day and were sort of an afterthought rather than getting the same attention that other patients would potentially get. And I actually did something a little different. I did a dedicated palliative medicine fellowship. So it wasn't a palliative rad-onc fellowship, but a palliative medicine fellowship. And then came back to Penn. I did that up in Boston, and then came back to Penn to set up our palliative radiotherapy program. So I see a lot of inpatients, I see a lot of outpatients. I actually attend on our palliative care service. So I see the heart failure patients do general palliative care as well a few weeks a year. I'm doing that again next week. And our program has actually grown pretty dramatically. We've seen pretty significant increases in numbers. And as Dr. Johnson said, we can see patients at all different stages of their disease trajectory, from oligometastatic disease to very end stage disease. And we treat lots of people with single fraction radiation, lots of short course radiation. So I absolutely adore this work. Thanks for having me.
Dr. Shukla can, yep.
Everyone, I'm Parrish. I'm a PGY4 at Tufts, and I will be serving as your moderator this afternoon. Very excited to be here. So we will continue forward with some cases. And first up will be Dr. Kotek. So I will let him take it away.
Okay. All right, so this is a case of a 65-year-old man. He presented with a left supraclavicular mass back in 2018. FNA showed melanoma, and a PET CT at that time didn't show any other sites of known disease. So he started on immunotherapy, and at the this is a photo from October 2018. His mass was relatively stable at that time. You can move on. So finally in October, it had progressed slightly, so they switched him to intratumoral injection of this toll-like receptor agonist and ipilimumab on a trial. Unfortunately, 3 months later, he progressed again. This is kind of what I was alluding to, patients going from trial to trial. Then went on to another immunotherapy trial, again, progressed very quickly. This was 2 months, and then made it to my clinic in July of that year. And when I saw him, he had a greater than 10 centimeter diameter mass in that same location, had really severe pain across the left neck, chest, and shoulder. It had a pain pump placed, didn't have any arm weakness, numbness, or paresthesia, so no brachial plexus involvement as far as we could tell. It didn't have any other known sites of disease at that time. So you can go to the next slide. This is what it looked like in clinic, a pretty dramatic increase in size from that prior photo, which is what I was expecting to see when he was scheduled with me. On the CT, it's quite sizable and is almost touching his chin. And the pain was just excruciating, unfortunately, with even really high doses of pain medication. By this point, he had actually undergone palliative procedure, I believe a nerve block, and again, no relief in pain. So yeah, you can go on to the next. So what would you recommend? So we have 8 to 10 gray in 1 fraction. I tried to cover all of the general options, 20 to 25 gray in 5 fractions, 30 gray in 10 fractions, longer course fractionated regimen, SBRT, or something else.
So we've got several answers coming in. Can people see the answers as they're coming in? Most likely not. Oh, you can? Okay, great.
So it looks like we have 30 gray and 10 fractions with 32%, SBRT and a lower dose 5 fraction regimen, each 23%, longer course fractionated regimen 14%, 8 to 10 gray, 1 fraction 9%. So when I'm thinking about how am I going to approach this tumor, like what dose am I going to use? And we talk about dosing a lot in palliative radiation. I feel like we're obsessed with it more than maybe some other subsites, particular subsites, because almost anything goes. So I think about what's the goal of treatment. So are we trying to just palliate a symptom? In this case, we are, but we're also trying to get local control of disease. So maybe we need a higher dose if we're trying to get local control. He doesn't have any other sites of disease. I think about the tumor histology. If I have a breast or a prostate cancer or ovarian cancer, I'm thinking, okay, that's radiosensitive, lymphoma, myeloma, radiosensitive. So we can get away with lower doses of radiation, but with melanoma or renal cell or colorectal, we're going to need a higher dose in order to achieve local control if that's our goal. And it is important to define what the goal of treatment is ahead of time. Other things that factor in are what is the patient's performance status? What is their expected survival? This gentleman walked into the office. He felt fine. He was going on trips abroad. He was, very functional aside from this pain from this mass. And then also factoring in is what systemic therapy options do these patients have? So this gentleman had already been on 2 clinical trials. He's out of options, but as someone who's really functional with a lot of options, without a lot of systemic options, I wanted to be as aggressive as possible. So for me, I felt like single fraction wasn't going to cut it. And a lower dose 5 fraction regimen or 30 and 10 wasn't going to be enough. I really didn't want to bring him in for weeks and weeks of radiation. You could argue it's oligometastatic and he was willing to do it, but he did live a distance away, and melanoma maybe doesn't respond so well to standard dose, standard fractionation. So I considered SBRT. In fact, that's what I was thinking I would do until he came into my clinic with this huge tumor sticking off of his chest. So I opted for something else, and we can go through what I opted for. So we can go to the next slide. So I decided to do a regimen called quad shot, which you probably heard of. It delivers radiation over a short course, but multiple cycles. So it's 3.7 gray given over 4 fractions of 3.7 gray given twice a day over 2 days. And this is also referred to as the Spanos regimen. It originated in the palliation of pelvic malignancies in RTOG 8502. The precursor to that study was RTOG 7905, where they gave 30 gray in 3 doses of 10 gray at 4-week intervals. And the first graph over there, the top graph on the right, shows the grade 3 complication rate, which was quite high with that regimen.
Can I just interject so we can have some conversation, which I think is part of the goal? I think one of the interesting and rarely noted things of RTOG 7905 is it was similar initially to the quad shot in that it was 10 gray delivered once a month and then repeated if necessary. And it wasn't until they did the 3rd dose that they saw those high rates of toxicity. So when you did 10 gray times 2 once a month for 2 months, it had very effective rates of palliation, but not those high rates. And that seems to have gotten lost. The other thing I like to point out when talking about that study, and I'm not, again, I don't disagree with the quad shot, but I just think sometimes it's useful to delve into the details of these studies. So I think 3 times 10 gray is probably too much, but 2 times 10 gray probably isn't. And when you think about the era in which this was done, I mean, it was started in 7905. This is basically 2-dimensional treatment planning whole pelvic fields or mini pelvic fields, but basically based on bony anatomy. And so with modern 3D based planning, whether you use advanced technologies or not, I don't think you necessarily need to, but our fields are almost always smaller than that. And so probably less toxic. I'm not saying I use 3 times 10 often, but I do sometimes use another regimen that's been published in the pelvis of 3 times 6, 7, or 8 gray, and my fields are more conformal with very good rates. And so it can be a nice regimen. The 6, 7, or 8 gray is typically given either every other day or once per week. And so I think to be mindful, one of the reasons that trial had so much toxicity is because they did go to the people who went to 30 gray, and they were huge fields comparative to what we might typically see today. Sorry about that.
No, I agree completely. I don't think that, I think that this idea of giving radiation in more of in this format where you're giving kind of a cycle of radiation, I mean, you can give it every other day, you could give it weekly, or spaced out by multiple weeks. I think it's just a different way of delivering dose that can be effective in certain situations.
I also think that, people say things like radio resistance of melanoma or renal cell. And for that reason, sometimes the higher fraction may be, higher dose per day may be beneficial. And at the other end of the spectrum, I sometimes see and have treated patients with single fraction for melanoma or renal cell, and they respond quite nicely and have local control. So I think one of the problems is that all tumors are different, that biology, responders respond, and they'll probably respond almost whatever regimen you use, which is one of the things you said earlier, that there's almost no rules in palliative radiation because the dose schemes are all over the map. And everybody has their favorite regimen, which is often based more on anecdote than data, because the data is really sparse.
Yeah. So the RTOG 8502 delivered this quad shot regimen of 3.7 gray 4 BID, had excellent effectiveness and a low rate of toxicity when delivering 3 cycles. Okay, we can go on to the next. So quad shot is now becoming more in vogue in head and neck cancer. I've seen quite a few publications on it in that site. This is a paper out of Memorial when I was there. So I was kind of indoctrinated with the quad shot when I was there. But the benefit in head and neck cancer is that you're delivering a dose that's generally below the threshold for mucositis. And I treat a lot of head and neck cancer. So especially in patients who have a lot of comorbidities, borderline performance status, and elderly patients, this is an option. Higher dose per fraction, like 10 gray single fraction regimen, is also reasonable, and also is low toxicity. But the idea is that you're giving a cycle of treatment, letting patients recover from that, and then coming back with more radiation, which I think can be helpful in that setting. So this is what we did.
Just to add also, not just recover that, but you can see treatment fields respond. You can see response, and you can shrink your fields both with the monthly intervals. So it has lots of advantages.
Mm-hmm. That's right.
And I would say that in responding to the questions in the chat, yeah, usually we are going to replan, particularly with something that is this big. Because if you don't replan and you're treating with IMRT, your doses may look very, very different if you end up with a good clinical response. The other piece that I would just point out is that you've contoured it here with the brachial plexus, but the brachial plexus is actually what I would worry about the most with replanning. Because if you end up with a hot spot on the brachial plexus, if you're doing quad shot, brachial plexus is usually going to be fine. The EQD2 for quad shot is about 63 gray. So you're probably going to be okay over plexus, but if you have hot spots, you got to be aware of that.
And it isn't essential, and we did VMAT because I saw this gentleman, and initially up front was thinking, I want to plan as if I'm going to give 4 cycles of quad shot. So I want to give, keep the brachial plexus to a safe dose. I want to be able to get as much radiation in here as I can safely without causing a lot of toxicity. I felt like if we did SBRT that we would cause a lot of toxicity. I was worried about how his skin would hold up with a high dose like that. And I felt like doing more conformal treatment like this was reasonable. So we simmed with bolus. We made a thermoplastic mask, and it's a pretty straightforward treatment. I kept the brachial plexus maximum dose to around 12 gray. It certainly would be safe to just treat with opposed fields in this case. I mean, if you need to get treatment going quickly, it's more than safe to do that. I was hoping that this would shrink, but I was trying to keep the brachial plexus to a dose where I felt comfortable giving 4 cycles of this without having to worry about the brachial plexus dose. And unfortunately, it didn't shrink, but you can see from the different quad shots spaced about 3 to 4 weeks apart that there's developing necrosis in the center of the tumor, even just a few weeks after we started radiation. We did re-sim each time, but I think the hope is that with more adaptive radiotherapy, I think WashU has a trial ongoing now about can we just skip the re-sim and do adaptive radiation at the machine. I think they're doing that with the ethos unit. So that's a possibility. But for right now, we're re-simming and sometimes using the same plan, most of the time replanning. And by the 3rd quad shot, we start to see some response in the tumor. Pain was much better. And although I didn't really have much of a chance to assess whether the radiation was working, the patient felt better even before the 2nd quad shot. He could tell that there was a difference. Now, if this tumor was, yeah,
it does look different. I'm sorry. It may not be, I mean, it looks like it's contracting over the course of those 3. They may not be substantively different in volume, but they do visually look different, at least on the slices you chose.
Yeah. I tried to be agnostic about it and pick the slice at the same level of the patient's anatomy.
So I would also just add that often you're going to see, if you go back to that slide one more time, you're often going to see necrosis the way you do here. And the way that you're going to evaluate that clinically is that you're actually going to palpate this mass, and often it's going to be softer. And so you will often be able to tell, patients will often be able to tell even before we get imaging that there's been a clinical response.
Well, and their pain score may decrease also. I mean, I think you can do adaptive radiotherapy on the MR-Linac, and many institutions now have the MR-Linac, and it's quite slick. Although it's certainly not necessarily easy on patients. They're often on the table for about an hour for the adaptive planning.
The other thing that was striking to me is that this mass was going up to the skin. We put bolus on it. We made sure that we got full dose of the skin, and he really didn't develop any dermatitis to speak of. Other than the mass shrinking, he didn't really have any toxicity from the radiation at all, which was great.
Interestingly, I think that's very common. Kavita presented a wonderful head and neck cancer case involving the mandible and the oral cavity, and gave someone the quad shot, and actually just after one course of it, because it was myeloma, and he had to go on to a trial, but no mucositis. And I find that absolutely intriguing, that it's a wonderful regimen, it's specifically designed, I think, to be below the development of acute toxicity, which people always we worry about acute toxicity, especially in palliative cases. But this regimen was essentially designed to avoid it.
So he continued to respond. Eventually, in I think November of 2019, he had a chunk of the tumor just kind of come off, or it eroded away the skin, and kept shrinking and was essentially resolved for a time. Pain was much improved. But then in February 2021, he did have growth of one of these 2 residual nodules. I gave quad shot just to that small area. And again, he had a complete response. And just over the last week or so, he started to progress in other sites. But he got 2.5 years of time out of this without really any toxicity.
All right. Thank you very much. We will move forward with our next set of cases. And just as a time check, I will caution we're about 25 minutes in. So we'll try to keep these next 2 to about 15 minutes each, so that we'll have a few minutes for questions at the end as well. So this is
Certainly.
Charles, please
So
take it away.
this is a case to kind of speak to the biology of tumors. So this is Mrs. T. She's a 61-year-old woman who has no insurance. She presented in 2016 with severe back pain. Because she had no insurance, she had an unattended breast mass because she's perfectly reasonable, but was afraid of the cost of therapy. And so it essentially dealt with this until her back pain became unbearable. She first had a lumbar spine x-ray and then a CT scan, which showed a pathologic fracture at L4. And you can see the PET scan there with the biopsy showing grade 2 ER positive, PR positive, HER2 negative with a Ki-67 of 10%. On her PET scan, she also had the breast mass, axillary adenopathy, the L4 lesion, a right rib lesion, and a sacral lesion. So poll 2, how would you treat? 8 and 1, 20 and 5, 30 and 10? I didn't give you a something else, but. Interesting. I expected more 30 and 10, but I'm glad to see at least 50% of the group had 20 and 5, and a small handful had 14%. So I'll ask a subsequent question. Remember, this is 2016, so before the publication of Saber Comet. What was a reason not to use 8 gray in a single fraction in 2016? So for all of you who did not choose 8 gray in 1, why would you have not treated? Oh, okay. So this is one of the myths that I hope to dispel, especially with this case. 30 gray and 10 is more durable. 63% chose that. Oligometastatic disease. Again, this was before the publication of the Saber Comet. 40 and 10 is probably an old school thing before the ASTRO guidelines, but when I was in training, people would often give breast cancer 40 and 20. And this is my favorite, no good reason not to use 8 gray, which is what I chose. And that I think is the correct answer in this case. So let's look at the next slides. So in July of 2016, I gave her a single fraction of 8 gray. You can see I did one above and one below. She also started letrozole, and then palbociclib was added a few weeks later. She had no acute toxicity, no bowel toxicity. People always look at those curves and say, what about the bowel? This is a low overall BED, despite the high dose per fraction, and can be very, very well tolerated. I typically give people Zofran 1 hour before treatment just to prevent nausea, because that can be kind of problematic. And I warn them about a pain flare. Anyway, so that's what we did. Okay, next slide. So this is her response. October of 29th, 2016, 3 months later, she had L8 gray only to L3 to 5. She has a complete metabolic response, both at the lumbar spine as well as all of her other sites of disease. So the story wouldn't be here if it was that simple. So she continued on letrozole and palbociclib. In February, she had isolated uptake in her right fourth rib, which you can see there. I've shown you the slide of L4, which is sclerotic, but there is absolutely no FDG activity. Now, mind you, this is 2.5 years after the radiation therapy. So for all of those who said 8 in 1 is not durable, there are plenty of examples where it's the biology, not necessarily the dose that matters. And so what did I do? I thought, well, it worked before, let's do it again. I gave her a single fraction of 8 gray on April 1st, 2019. But this time it wasn't so straightforward. So if you can advance the slides.
So it's harder and rough. We just have an interesting question in the
Okay,
chat.
I'm
So
sorry.
the question is, do you ever treat using just a simple PTV margin around the involved spine level, given 3D capabilities and every within that future treatment? So in other words, instead of going one above and one below.
Right. I am old school. I would say I do that for SBRT. But if you go back to the slide where you can see my dose, one of the reasons I do one above and one below, and I think historically they knew this, is that your 100% isodose line bows in. So you think you're treating a lot more, but you're really getting full dose only to that vertebral body. And so if you only added a PTV, you wouldn't have, I think, the coverage. I think people worry about the toxicity, but with matching fields and advanced technologies, and by the way, if this came back, 8 gray in a single fraction could be given at least once more, because this is below the level of the spinal cord, and 8 gray can be given safely twice, and possibly 3 times if it's not where the spinal cord is. And so I don't use that habit except when I'm doing SBRT. I don't think it's wrong, but I think one of the mantras from my training was, in palliative radiation, don't miss, and when in doubt, make the field bigger. And I think you want to make sure that you treat the problem in one cycle or in one course of radiation rather than having to go back again.
And I would say that I do something very similar. I also, I treat one above and one below. If it's a really big field, then I might try to limit it a little bit. I might cheat a little bit, but in general, you'll be kicking yourself for not treating it rather than wishing that you didn't.
Exactly. And I mean, for a different case, someone with multi-level disease, I may decide to half beam block either above or below for future field matching. Although with modern radiotherapy, you can also match divergent fields very well, kind of like craniospinal, and it's not as complicated as it used to be thought. So we're not doing gap calculations and whatnot. We're just looking at on a 3D plan. But sometimes I pick the wrong side to half beam block, but you can certainly match fields later on down the line if you need to. So this is after her treatment. She had a response at the rib, no evidence of disease. And that was 4 months later. But on her next scan, which we'll show here, in May of 2020, about a year after the 8 gray in a single fraction, she has a restaging which shows only the right fourth rib lesion. L4 was still FDG negative 5 years after 8 gray times 1. And she was treated with SBRT 30 gray and 3 fractions of 10 gray. By this point, the Pall data had come out. There was more excitement about oligometastatic disease, and it was more normative. And, I think it shows the biology. She got 2 lesions, one completely controlled with 8 gray in a single fraction that was completely pre-treated. This is 5 years later, or 4 years after her initial presentation. The biology of her tumor is probably a little bit different after 4 years of letrozole and palbociclib. But the interesting thing is she remains disease. You can turn to the next slide. Disease-free. This is June of 2021. No evidence of disease. She's on the same systemic therapy. Because we treated her for oligoprogression, she didn't have to change therapies. And the 8 gray times 1 to the sacrum was controlled at L4 for 6 years. And I just want to show you some slides that show the data, because I can't tell you how often I hear 30 in gray in 10 is more durable. And when I was in training, I think it has differed now because I've been out of training more than 15 years. If someone recurred after 30 in 10, we didn't retreat. The people thought the spinal cord couldn't tolerate anymore. You just did not retreat. And so I think most people did not retreat after 30 gray and 10, but they felt they could after 8 and 1. And so when you compare multi-fraction data to single fraction data, the overall responses are the same, complete responses are the same, development of pathologic fracture is the same, and development of spinal cord compression are the same. The one thing that people always say is the retreatment rate is higher after single fraction, and people use that as a rationale to say it's less durable, but I think people felt more comfortable retreating after that dose because it's a lower biologic effective dose. You show the next slide. This is another slide that shows kind of the same thing from a different study. But what I want to highlight here is that the time to response is the same, whether they were seeing single fraction or multi-fraction. On average, people take 4 weeks to respond. So if they're on 30 gray and 10, their response comes 2 weeks after treatment. Whereas if they've gotten a single fraction, they have to wait a whole month on average for pain relief. If you look at the duration of the response, it's the same, 29 weeks versus 30 weeks, and for mean and median of 35 and 42 weeks, which are not significant. And so on average, the pain relief lasts the same amount. The difference is we use the retreatment rate as a surrogate, which it's not a very good one for. You can see that 55 and 53% of patients have progression of pain at that site. This is randomized data, and that time to progression is about equal 17 and 18 weeks. So I hope you will use this to understand. I do not think the data suggests that 30 and 10 is more durable. This is another study showing the same things. I think the slides or the PDF would be made available to everyone. But these are in long-term survivors, patients followed until death. Half of them were alive at 28 weeks, 32 had more than 1 year survival. When they looked at their data, there was no difference in pain outcomes, but there was higher retreatment rates, but the time to retreatment being needed was equal, and 50% of radiation was within 4 months, which interestingly is the same number as the prior slide, 16 weeks. And so it's overall very consistent data that people progress regardless of their initial fractionation. And I like to use the lower biologic dose so that you can save something for the next time when you need to retreat them again, if you need to retreat them. There's a gap, if you were to use 30 gray and 10, do you ever retreat? And so I'll answer that after this. But so I would submit to you that people have been giving biased presentations. Instead of showing the graph on the left, which shows exactly overlapping curves in terms of mean pain scores, they show things like graphs on the right, which shows significantly different retreatment rates. And so I think we've been giving biased presentations, partly because our billing systems favor multifraction treatment. I think that's what I'll say there. I do retreat after 30 gray and 10. I kind of curse the radiation oncologist, just kidding, who did that initially. But I think if someone's given 30 and 10, they've limited my options. I always refer back to the Chow meta-analysis and the inclusion and exclusion criteria. They have a huge section on who was eligible for the trial. And interestingly, because of bowel dose, if they got 30 gray and 10 to the pelvis, I think they were ineligible for the study, or they were eligible, but then they would either get 20 gray and 8 fractions or 8 and 1. So 20 and 5 was not felt to be safe to the pelvis because of bowel dose. And so that paper has some really nice, people thought very hard about a randomized trial, what prior treatment regimens were allowed and what could be done for future. And so I do think if someone's received 30 gray and 10, it severely limits you. I think you can safely do 8 gray and 1 after 30 and 10, but again, you have to be careful of the normal tissue toxicity, where you're treating, where the hot spots were, and all that good stuff. And unless Dr. Kutek or Dr. Jones have any comments.
I just put some stuff in there about Kirsten Peters' data. There's some really nice data about retreatment over the spine and conventional dose fractionation and what's acceptable with a BED. So, yeah.
So yeah, we can move forward with Dr. Jones. Dr. Johnstone, thank you so much. That was a really great discussion. I know you've opened up my eyes to this, and I hope that other residents are able to hear your view on this as well and potentially upgrade their practice. But we will move forward with Dr. Jones, and he will be discussing a case regarding the leptomeningeal disease.
And I would just start by saying that, as you see from my picture, things change over time. So I want to talk about a woman that I recently treated, as opposed to our other panelists who talked about, at times when palliative radiotherapy gets you some really incredible results and durable long-term results, sometimes that's not what we see. And so I'm going to talk about a 55-year-old woman. She had a T4B N3M0 right breast intraductal carcinoma. She was getting neoadjuvant chemotherapy with a plan for mastectomy, and she had just finished her chemotherapy. She was getting ready to be admitted for the mastectomy when she presented with, literally 2 days after her visit with a surgeon, with several days of headaches, diplopia, confusion, falls, and new severe back pain. And this was all down in the lumbar spine. Of note, she had prior left breast lumpectomy and radiation, as well as tamoxifen in 2005. So this was 16 years before presentation. MRI, unfortunately, revealed diffuse leptomeningeal disease. And I could have put any number of different slices here, but you can see that there is enhancement along the sulci, that there's enhancement everywhere. It is really quite a remarkable case of leptomeningeal disease. And even on the spine, you can see that there's enhancement, and there's clumping nodular enhancement within the spine. Next slide. So our initial approach, as usual, was to start steroids. There was a lot of discussion back and forth. Do we need an LP? When is an LP safe? The steroids led to complete resolution of the cranial neuropathies as well as confusion. And then the question came up in this woman with triple negative breast cancer: what is her prognosis, and how do we think about that? How do we think about caring for these patients when time may be short? And how do we think about it also in the context of somebody where this is not, this is a radical shift in the treatment that we had providing. Yesterday, we were talking about cure. Today, we're now talking about palliation and potentially end-of-life care. And so I wanted to spend a couple minutes thinking about that. Next slide.
So I'll just jump in here with a quick question in the chat, since we're doing great on time. And I think Dr. response to all of it, but for palliative spine cases, is there any consideration for a spinal cord sparing approach? And I'm sorry to switch topics. So essentially, is there any consideration to a cord sparing approach to potentially leave more?
I can, yes, I said I think it's unnecessary. One of the most wonderful articles is written from a Canadian, Dr. McMillan, who said palliative radiotherapy should be no more expensive than necessary, should be no longer than necessary to achieve the results, and no more complicated. And I think certainly if they got definitive treatment upfront for lung cancer and have spinal cord compression in that area, possibly you might need to do something to protect normal tissue doses. But for straightforward palliative cases, I don't think there's any good data. You'll run up people's bills, you'll make things more complicated. And I think Josh agrees with me, and I'm sorry, I didn't mean to cut you off, Josh.
Yes, I agree. And in this case, when we're treating the spine in somebody with leptomeningeal disease who has severe 10 out of 10 low back pain, not only would I recommend against this, but you cannot, because this is leptomeningeal disease, and so you need to be aware of what it is, what your target is. So for this lady with leptomeningeal disease, I just wanted to point out, I don't want to go through the ESMO guidelines, but there's not a huge amount of data for how we manage patients with leptomeningeal disease, but there's a really nice consensus article from the European Medical Oncology Society group, where they actually go through what should the diagnostic workup be. They talk about nodular versus linear leptomeningeal disease. Is this concern confirmed on cytology? So they have lots of different pathways to think about. And I think it's worth being aware that these exist, even knowing that the data is pretty sparse still. And the answer is it needs to be an individualized approach for every patient. So knowing this, can we go to the next slide? When we're thinking with somebody like this about prognosis, we actually need to ask, because there's a lot of data in the literature that patients and families think that if we think it is important to talk about prognosis, we are going to tell them. And many clinicians think, oh, if the patient wants to know, they are going to ask. And so we talk past each other quite frequently. And I think it's really important, as we are talking about this, to think with patients and families about prognosis and asking how much information about prognosis is important to you. What kind of information can I provide to you? And it doesn't necessarily have to just be about time. And if the patient doesn't want to know, the question that we need to ask ourselves, is it going to impact decision making? If we're thinking about various different treatment options and they would pick something that is intensely aggressive, but might put them through treatment up to the end of their life, we need to be thinking very, very carefully about that. Next slide.
So, Dr. Jones, in your practice, do you proactively ask the patient before they have asked you regarding how much they want to know about the prognosis, or do you typically wait for them?
Yeah, so I start with a question before this, right? So the question is, what have you heard about your illness? What have other people told you about what we're seeing? And if they say, look, I've heard that I have leptomeningeal disease and that time may be short, well, then I'm not going to push them very far. If they say, oh, I have headaches and I'm going to be cured, then it becomes really important to take that step back, because the approach for treatment that we're going to offer hinges on how much they know. And so we need to ask. And if they want to hear about time, we need to be thinking about talking about time in ranges. If we want to be you want to be very, very gentle, for somebody with leptomeningeal disease, you can talk about uncertainty. I hope you do well for a long time. I'm worried there's a possibility that you could get sick very quickly, right? And that is as gentle a headline as you can deliver. It provides the information and helps them to think about, hey, if I'm going to get sick really quickly, and sometimes I'll even say you may get sick quickly to the point you might die. Depends on what their performance status is, what they look like, and what we're thinking about offering together. I hope that makes sense. And the other piece that we need to think about is we're talking with patients and families about this. And I wanted to put a couple slides in here because I spend huge amounts of my time teaching our palliative medicine fellows, teaching our rad-onc residents, our med-onc fellows about communication skills. And if we are so focused on talking about our treatment options or talking about the prognosis, and we miss the emotion in the room and our opportunities to respond to the emotion, then we miss really important opportunities to connect, to build that clinician-patient relationship, and to help them with their decision-making as we're moving forward. And if they're sharing, if they start to cry, if they are upset, if they're distressed about information that you shared, it doesn't mean you've done something wrong. It means that you've gotten a point across and they're processing it. And so, next slide. It becomes really important to think about, well, how do we respond to these emotions? So, and this is a very simple mnemonic, the nurse statements, naming the emotion. It sounds like this must be totally overwhelming. Understanding the emotion, really understanding empathic statements about it must be so hard to be in pain. Respecting and praising the patient. You have been through so much. You've been so strong through so much. Using these statements, the alignment statements, we're going to support you through this, can be immensely powerful to help us to understand where the patient is coming from and help us to help them to make appropriate decisions. Next slide. So as we're thinking about this, there are lots and lots of possibilities here. If we're looking at the ESMO guidelines, they talk about a life expectancy of less than 1 month. Usually, any treatment for leptomeningeal disease is not going to be helpful if our prognosis is less than a month. If the prognosis is 1 month or greater, well, then we can think about, should we be considering systemic treatment? Should we be thinking about intrathecal treatments? And then what we're going to talk about, which is radiation treatments. And there's no randomized data that suggests that there's one approach that's better than the other. It is important to know that for all comers with leptomeningeal disease, still in this day and age, unless you have an EGFR mutation, or something where you have a targeted treatment that crosses blood-brain barrier, for all comers, median survival without treatment is still measured in weeks, usually 6 to 8 weeks. So can we impact that? Yes. How would you approach treatment for this patient? So she's got metastatic disease with leptomeningeal disease that looks ugly. She's got a poor performance status, which is the strongest predictor of survival. And our options could be craniospinal radiation, whole brain and whole spine. The challenge there is toxicity. We could think about whole brain radiation, whole brain and focal spine, focal skull-based radiation, because we're worried about her picking off more cranial nerves, plus minus spine radiation alone, or hospice. And all of these are reasonable approaches. And then the question becomes, what dose and fractionation? So are we doing 30 and 10? Are we doing 20 and 5? Are we doing longer extended dose fractionation schemes? And you can see what these look like here. And at Penn, sometimes with these patients with a long anticipated survival and a good performance status, I will treat with proton craniospinal radiation. You can spare tremendous side effects. I generally am not doing conventional craniospinal radiation because the toxicity is incredibly high. And patients are not likely to live much beyond the end of a craniospinal radiotherapy course. Next slide. As we're thinking about craniospinal, again, if you do think that this is something that you want to consider, we've got conventional craniospinal radiation, proton craniospinal, you can do arc therapy. So there are lots of different ways of thinking about this. But as Candace said before, we want to be thinking about what is our goal? Are we palliating symptoms? What's the fastest, most efficient way to do this with the least side effects possible? Candace, you look like you were going to say something.
Yeah, I was going to, and I didn't mean to interrupt. It's more towards the focal radiation than the craniospinal. I mean, if they really poor prognosis, I mean, there's data to support 8-gray and 1 for neuropathic pain, for spinal cord compression. And certainly I don't think there's probably much data on it in leptomeningeal disease because the data in leptomeningeal disease is so poor, but it can certainly be a reasonable tool in your toolbox for those people who might then go to hospice to help preserve function until they get to hospice or while in hospice.
So I would just say, I agree, there's not good data for 8 and 1 for this, but I've done it many, many times, and I've been incredibly impressed with the benefit. The only time where I wouldn't do 8 and 1 is whole brain. There's no good data for 8 and 1. The study that looked at whole brain 8 and 1, actually patients had a moderate risk of seizures after 8 and 1. And so there's some data for 6-gray times 2. And so if you really want to treat somebody with a very short course of whole brain radiation, trying to, I've done this, for example, for a patient who had gone blind in one eye, was at home on hospice, wanted not to die blind, was rapidly picking off cranial nerves. So we did 6-gray times 2 over 2 days. And so there are other ways of thinking about that too.
Right. And just to be clear, I was talking more about when you talked about focal spine radiation or like focal skull base to do that. I agree. And 6 times 2 is a reasonable regimen for brain if you need to do something quick.
So we only have a couple minutes left. I want to make sure we have time for questions. So what did we do here? We talked with her at length. And we spent, I was incredibly worried about her. Even though she was being treated with curative intent, her performance status by the time she ended up in the hospital was terrible. She was easily an ECOG 3, maybe an ECOG 4, had very minimal improvement. Just the cranial neuropathies improved with steroids. We decided to treat whole brain and lumbar spine, 20-gray and 5 fractions. She had she had significant improvement in the back pain, the headaches, resolution of the cranial neuropathy. She went to rehab. She was excited to be going to rehab and then getting to home. And then she was readmitted 3 weeks later. The disease on the spine had grown explosively. We ended up treating her with 20-gray and 5 fractions to much of the cervical and thoracic spine. She actually tolerated it surprisingly well with low dose. You can actually tolerate that relatively well. She never received systemic therapy, and she died on hospice a couple of months later. So did we help her? I think we got her significant pain relief. We were able to maintain function for a fair amount of time, and I think we did get her some benefit.
Yeah, I did write in the chat, there was a question about CSI, and I think if you don't have proton radiotherapy, toxicity of craniospinal is significant with GI toxicity. No matter how you do it, it's very marrow suppressive. And this patient didn't have craniospinal, but still was never able to receive systemic therapy. But the marrow suppression, if you treat the whole spine, can be unbelievable.
Yeah. So there was a question about how long does it typically take to see pain relief response after focal RT to the spine? And it's relatively quick. There's some data. There is some data from Germany about responsiveness to steroids predicting response to radiotherapy. And so usually I'm going to have conversations with patients and families. If we don't have other good systemic therapies, targeted therapies, I'm going to have conversations about hospice versus short course of radiation. If you are going to see it, usually you're going to see a response within, start seeing a response within 7 to 10 days, 2 weeks. And how quickly can you see it? Within a day. I've had some patients improve within a day.
I think it's the biology. You know, there are some people who respond really quickly and others that lag. And, you know, in this disease with leptomeningeal disease, they may die before they see a response. You know, if they're really got bad biology, but heavily pretreated.
Yep.
Okay, so I just want to say a quick thank you to all the panelists as well as all the attendees for asking some very engaging questions and participating. I think this was a very lively and informative discussion. So thank you for that. Also, thank you to Navjot Sandhu. She's our ROVER 2.0 coordinator, and without her, this would not be possible. So major props to Nav. Be sure to please fill out the post survey. It does help us to get feedback and continuously improve these sessions. And finally, please feel free to contact us. I'll leave the emails of some of our co-founders and faculty advisors here. And then finally, just a quick plug for our December session happening on the 10th. It's a continuation of our Rocket series in partnership with ARS, and we'll be discussing interview tips, job offers, etiquette, and contract negotiation. So very exciting panel that we have lined up for everyone. Any final comments or thoughts from anybody?
Thank you. Good job. Thank you, panelists.
Thank you, everyone.
Thank you.
Thanks all.
Thank
Have a
you for
great
inviting
weekend.
me.
Bye. You guys were great.
Bye.
Bye.